Hi, Dr. Brian Kaufman here at Ash2018.
And my name is Michael Hallek from the University of Cologne, and I'm happy to share some thoughts with you.
Professor Hallek, one of the new exciting things we're seeing a lot of here at ASH this year is new combinations of very potent agents in CLL. And I know you have opinions about should we be sequencing these, should we be combining these, and I'd like you to share in kind of a patient-friendly way what your thoughts are, what your logic is on that, based on some of the data that we've seen here. Very exciting data.
So as you say, ASH this year is full of exciting news. One of the major topics to me is the two different concepts that have come up with very interesting data. We have seen at the plenary session yesterday by Jennifer Boyach, ibrutinib monotherapy beats BR. We will see tomorrow at the late-breaking abstract session, ibrutinib monotherapy is eventually better than FCR. So there is one piece of data suggesting from randomized trials that monotherapy with single-agent ibrutinib is a very strong therapy, beating older chemoimmunotherapy that are fairly potent. And then there is these combinations of novel agents, venetoclax plus ibrutinib, venetoclax plus obinutuzumab, or even triple combinations, and they have a totally different concept, fixed duration. They target MRD negativity, so minimal residual disease negativity, and they aim to have a short duration of therapy and then a therapy-free holiday, if I may call it this way, for a long time, so maybe for years, if not longer. And we don't know at the present time which of these concepts is going to be the better concept. I'm clearly advocating combinations because they allow patients to stay off drug and off treatment.
And let me ask you, why do you think that's important that patients get off drug and off treatment?
Because in principle, I think that if you continue therapy, it's actually costly, it's cumbersome for the patient. It's do you have to think about it every day? And third, in some of the patients, you're actually breeding resistance. So the longer you have a disease like leukemia on therapy without deleting it completely, the remaining clones have a tendency to develop resistance mechanisms, and therefore you always have to watch for novel resistance mechanisms, while if you stop, then those resistance clones cannot grow up so quickly. So basically intermittent therapies may prevent this, or I mean, of course we are aiming for cure, so I'm not so much a fan of a lifelong monotherapy, if you wish, but rather for a short-term, potentially curative treatment. So but still, those two concepts at this meeting have come to the spotlight because one of the concepts, monotherapy, which I personally have not estimated to be this strong, has 1 and 2 randomized comparisons, and now we have the beautiful task to solve which of the two concepts, if you wish, is going to be the future first-line therapy. And we are going to do randomized trials to exactly test this principle.
So let me ask you, when you're talking about combinations, do you think this ASH is, except for some very rare cases, the end of chemoimmunotherapy in CLL?
Not yet, in my opinion. It is also a hot debate because some people believe that this is the end of chemoimmunotherapy. They neglect, however, that for some good risk patients, IGVH mutation, so highly mutated, plus a couple of genetic features, trisomy 12, deletion 13q, and also deletion 11q, chemoimmunotherapy can actually be potentially curative. So
in young patients who can tolerate the therapy.
All patients that can tolerate FCR, and only those.
Right.
And we have not solved the question, nor at this meeting, nor anybody else, anywhere else, whether chemoimmunotherapy in those patients is actually a better option than long-term ibrutinib. So there is still open niches. Overall, I think the time of chemoimmunotherapy is coming to an end in the next few months. Whether ibrutinib is going to replace everything in every single niche, I doubt it. I give you one piece of solid data we saw yesterday in this plenary section. the ibrutinib monotherapy does not outcompete BR in exactly this population. There's a similar or identical PFS, values are identical, so mutated IGDH plus favorable cytogenetic aberrations, chemoimmunotherapy is just as good as monotherapy with ibrutinib and simply short-lasting. So you have a 6-month therapy and then you can be off treatment for a long while.
So let me push you on that a little bit, because the chemoimmunotherapy, you have, not that ibrutinib is without adverse events,
Yes.
insignificant ones, but the chemoimmunotherapy, I worry more as a patient about the long-term adverse events in terms of that small but real risk of developing a secondary hematological malignancy, which can be much harder to treat.
Well, we have to look at the facts,
Yeah.
I can see almost as many side effects in all randomized trials with ibrutinib in terms of atrial fibrillation and all these, so it's not so clear, we should simply look at the long-term survival chances of those patients because of the difficulty for some patients also to tolerate long-term ibrutinib.
Right.
I mean, so I don't think that this question is clarified. I think it's a very good debate, like the one we are having right now, about the risk of secondary malignancies in patients with CLL following this chemoimmunotherapy is a little bit overestimated. So basically what I'm trying to say is we should not succumb to marketing. We should just look at the data.
Okay.
And the data say side effects in both conditions can be fairly high. Look at the real world data. For ibrutinib, where up to 40% of the patients have to stop therapy for all kinds of reasons, especially in the elderly population, where the risk of atrial fibrillation, of bleeding, of hypertension is much higher than in the younger ones. And all the trials that we've seen here are in the fit young patients. So ibrutinib in the 2 randomized comparisons, plenary session and also in the session of tomorrow, is on fit patients or on young patients. So it's not always reflecting the real world situation of the elderly patient who has to take ibrutinib and will eventually get side effects. So you see me carefully evaluating the evidence and saying that we should not too quickly jump onto the next wagon. I know that this is very fashionable, and in the US most investigators currently think that ibrutinib is replacing everything. I'm not there yet.
All right. Any other thoughts you think patients should be taking away from this ASH meeting?
An important message for patients is outcome is improving by whatever we discuss here. I mean, all these things are about to improve the outcome of patients with CLL, and it's beautiful news. And I think in the next 1 or 2 years, combinations will take over everything.
Professor Hallek, thanks so much for all the research
Thank you
you're
very
doing.
much.
Thanks.